we've heard now a lot about immunotherapy and where it stands in head and neck cancer. I want to turn to each one of our panelists and get their take on where does immunotherapy stand right now for patients with head and neck cancer. Barbara?
Well, I think it's a brave new day. For many years, we've put patients on clinical trials that have not yielded any changes in therapy. And now we see that there are agents which, albeit not with a very high response rate, can lead to durable responses and improve survival in patients with platinum refractory disease. And that's a wonderful thing.
Jared, what's your take home for immunotherapy?
These agents are absolutely inspiring, but they also do have real risks and toxicities. And those risks and toxicities are different than the profile that we're used to seeing with cytotoxic therapies. And so I think it's important to learn about those specific toxicities, such as, for example, hypothyroidism that we see at particularly high rates in head and neck cancer, and learn to respond to them quickly, to not hold off, not try to maximize benefit, to have early initiation of steroids, and early consultation either with an oncologist with more experience in treating these agents or in other specialties where appropriate at a low threshold.
Yeah, I think it's a great point that we have to keep in mind that these are really agents with different mechanisms of actions and therefore different toxicities. In a sense, the oncology community has turned to the rheumatology community to deal with all the inflammatory reactions, or some of the inflammatory reactions to immunotherapy. So thanks, Jared. Great point. And Josh, what's your take on immunotherapy, where it stands now?
I think that, as Barbara and Jared said, it's very, very exciting. These are exciting drugs with significant activity, but we should not let our fervor for this excitement lead us astray. So specifically, there's this concept of pseudoprogression, which we think about with immunotherapy, where the T cells rush into the tumor and it's a very nice story and it swells and it gets bigger on the image.
You don't love the cartoons?
But the problem is that the majority of the time when a patient has a tumor that's growing, especially in head and neck cancer, they're probably having progressive disease. And we need to withhold that excitement and really look at the patient in front of us and say, if they're symptomatic and their tumor's getting bigger, we've got to look elsewhere. We've got to consider clinical trials. We've got to consider another approach to treat that patient.
Great points. So now that immunotherapy is established in head and neck cancer, at least in the form of anti-PD-1, let's look to the future. And we now have seen some data about promising trials with immunotherapy. What do you expect, Josh, in the rest of 2017 and 2018?
Well, I think that really the key next step is how can we expand that degree of response rate? So right now we've got an exciting but limited response rate. So is that increase in response, can we achieve that through combination therapies? And we can combine the immunotherapies that we know, things like nivolumab and pembrolizumab, but also PD-L1 inhibitors and other immunotherapeutics, with chemotherapy, with radiation, and with other immunotherapeutics utilizing other checkpoint inhibitors. And I think that it's really a brave new day of evaluating how to do those combinations in a rational fashion. And I think that's a critical point.